Good afternoon, everybody. It's my pleasure to be here. It's my pleasure to have participated in a few of these meetings and in the June Roundtable, in which we did have some lively discussion. And as I participated in these meetings and with the Institute for Animal Agriculture around antibiotic use, I've really considered what is it that CDC really brings to the table when it comes to animal agriculture. We are not experts in animal husbandry. We do have our fair share of veterinarians that are applying themselves in a lot of very different effective ways in multidisciplinary teams. But in reality, our focus is on human medicine. And given that antibiotic use needs to be judicious in whatever use we have, whether it be for human medicine or animal medicine, I think that there's a lot that we can learn from one another in how antibiotics are best used, how we can do better in using them judiciously. At this meeting last year and in the June meeting, we did have somebody come from our hospital quality promotion program that is responsible for antibiotic use programs in the United States to speak about the use of antibiotics in human medicine and what the metrics are that we follow. And so I thought I would reiterate some of that, because that's what I really feel like we might be able to bring to bear in the discussion, is that interaction. The metrics that we use really fall into three categories. Now, there are some metrics that would probably fall outside of these categories, but these are the main ones. I think they're pretty straightforward: antibiotic use, antibiotic stewardship, and trends in antibiotic-resistant organisms. And I think it's important that we kind of consider what are the measures that we want to apply under these general basic metric categories. And I'll show you some examples from the human medicine side, and they're based on prescription data, and then facility data, and then, of course, the microbiologic data. But I think there's some corollaries to what can be done on the animal side. Prescription data, now you've got the veterinary feed directives. And, I think even more so than the human prescription data, the veterinary feed directives have a lot of information that can be very useful in measures. For instance, prescription data doesn't have on the prescription itself the indication for the prescription, whereas in the veterinary feed directive, that's a part of what that directive is collecting. And so there is some information there that I think would be very helpful in looking at metrics having to do with antibiotic use. And this is in addition, of course, to the antibiotic use data that's already collected and distributed about antibiotic sales. Antibiotic stewardship, I think that there's quite a lot that is already being thought about among facilities and among the organizations having to do with animal agriculture about what makes up a stewardship program, and I'll talk a little bit about that on the human health side, and then, of course, AR trends and spread. We talked a little bit about NARMs, but I think we need to do a little bit better than or collect data in addition to NARMs. And the first speaker really spoke to that quite a bit in order to understand what's going on better. So this is one graphic that looks at human prescription data in the United States. And it's a fairly simple type of graphic, and it just shows the number of prescribed courses of antibiotics per population of patients. And it just breaks that down by state. And then what you can see is that there are large geographic variations in the number of prescriptions that are prescribed to the population depending upon where you live. And the low is in Alaska there at just about 500 per thousand population. So about half of people will obtain a prescription in a given year, whereas in the highest state, and that's West Virginia, there are more prescriptions for every year than there are people in that state. So on average, everybody's getting at least one prescription every year. Now, there are some differences in the population between, California and Alaska and some of the other states where there are lower prescription rates and those that are higher prescription rates, but not to the extent that would make up what we see in the differences geographically. And this is really based upon what is that relationship between the doctor and the patient. What does the patient expect? What is the doctor's education around prescriptions and so forth. So there's a lot that can be done with this type of data to target educational programs and so forth. That's one. So here's the map about stewardship programs. This is facility-based. So these are your hospitals in the United States that have stewardship programs where a stewardship program is defined. And so this is basically saying there are X percent of facilities, meaning hospitals in that state, that employ a stewardship program that is based upon a definition of what that stewardship program is. And there's really a lot of work being done to implement stewardship programs, effective stewardship programs in every hospital in the country. And we would like to do that as a goal by 2020. What is a stewardship program? Well, the CDC has defined what a stewardship program really consists of. There are 7 key components of a stewardship program, and to have an effective stewardship program, they say you have to have all 7 components. There is, at this website there, a monograph that explains what each of those key components really is. And so this is one of the stewardship metrics that we employ now. And then, of course, the microbiologic. What is the effect of all of our efforts having to do with judicial use of antibiotic stewardship programs and so forth on the rates of antibiotic resistance in the United States? And this is just to say that we've been able to measure the spread of carbapenem-resistant Enterobacteriaceae, which is one of those bugs that have been labeled the nightmare bacteria, that over a 15-year period of time went from just a couple of cases in 2 states to cases occurring in 49 states, or I think it's 48 states there in 2016. We need to be able to measure what are our problems, I think, with these types of resistance. And on the agricultural side, I think the real whole is how does that look on the farm? What are the resistances that veterinarians are having to deal with in order to treat their patients? And then what is the resistance that we see in organisms that can also cause illnesses in people? So I will stop there with my comments.